Radio. We're going to talk to two wonderful people that have offered their precious time to come and talk to us about prostate cancer. I personally, I don't know too much about it, and I'm sure you don't too. But this is the time to learn, and we'll be talking to Dr. We'll be talking to Dr. David Osafo, a hematologist, oncologist. He's a cancer specialist trained in blood disorders and the medical treatment of malignancy. We also have the pleasure to talk to John. For the purposes of this interview, we know him as John because we cannot disclose his identity like I've said before. So, gentlemen, you're welcome to Mustbe5radio. How are you doing?
Oh, thank you. Very well, thank you. Thanks for having us.
Thank you so much. Thank you so much. So, we're going to break it down, and talk about prostate cancer. I don't know what prostate is. I may have a prostate. I don't know what it is. And I don't even know where it is. What is the prostate? And do I have one? And what is the function of the prostate?
So, as John said, I'm Dr. David Osafo. I'm a hematologist oncologist. The prostate gland is a male sex hormone gland that's anatomically placed, situated at the base of the bladder.
Okay.
So every man has a prostate gland. Women don't have it, just like women have ovaries, right, and men don't. The prostate gland function, being a male sex gland, is to provide the male sex hormone, testosterone. So it is under the instruction of other glands, from the brain, the pituitary gland.
Okay.
Male sex hormones are produced, testosterone, and that goes into the bloodstream for normal function of males sexually.
Interesting. So is it possible that a male can be born without a prostate? Is that possible?
It will be a very rare occurrence.
Okay. So basically every man has a prostate.
Right. Through normal development, you will be born with a prostate gland.
Okay. So, Dr. Osafo, what are the symptoms of prostate cancer?
Prostate cancer, actually, to be honest with you, in the majority of the time, more than 90%, more than even 95% of the time, doesn't present with symptoms.
Interesting.
It's a situation called being asymptomatic. So that's why screening for prostate cancer is very important. And screening is actually very simple, cheap, and available. It's by doing a blood test called a PSA.
Okay.
By the time you develop symptoms, it most of the time is quite late. And some of those symptoms could be because of metastasis, when it has spread outside the prostate gland to other parts of the body, particularly the bones. So you will present with bone pain. That's one of the symptoms. Okay.
So are there any early signs? Let's say I don't have good insurance, right? And I think, I'm fit. I do a lot of exercises. I try to eat well, right? So I avoid going to the doctor completely. Is there any sign that would make me question myself and say, hey, maybe I should get this checked out? That has anything to do with the prostate or the prostate cancer?
It's unlikely that you'd have any sign like that because by the time you develop any symptoms, it will be late. But even in people who don't have insurance, what I suggest is they go to a doctor, anyone, put a little money aside and do screening, preventative health care.
Okay.
So for instance, we'll get back to prostate cancer, but put aside prostate cancer for a minute.
Okay.
Diabetes, high blood pressure, high cholesterol, all these things are very common. The beauty about finding those things early is that you can control them with diet and exercise before you need to get on medication. So if once a year you go to a doctor, anyone,
right,
you call the office and say, I want to come for a general health screen. So you go for a physical exam and you do labs. You find out whether I have high cholesterol, high blood sugar, which is diabetes, high blood pressure. They'll measure that in the office.
right.
And also you ask for a PSA. So back onto why we're on radio today, you ask for a PSA. Let that be part of your labs, because that's the most effective screening test. And like I said, it's available, it's cheap, done once a year. You can always handle it.
All right. So interesting. I'll come to John in a second, right? But I'm a little stubborn, right? There's no family history.
Right.
Should I be worried?
Since the screening, I would ask you to do it, but not be worried.
Okay.
Because you've got to remember one basic fact of life too. You said something very important. You don't have a family history. So
Right.
we all know that prostate cancer is more common in people who have a family history.
Okay.
But Michael, do you know something?
No.
That for people who have a family history, it started in one person, one day, somewhere, then it became a family history.
That is true.
So how do you know you're not going to be the one to bring it to your family? You don't know that.
Right.
So it's still important to get screened.
So talking about PSA, right? The PSA, I just looked it up right now. It's what? Prostate specific antigen. Is that correct?
Yes,
Okay.
that's correct.
Now, can I fully rely on this PSA?
Yes, you can. As a screening test, it's very reliable. You see, a screening test, getting into the statistical significance of blood tests, a screening test is one that has high sensitivity,
Okay.
which means if the disorder is present, this test has a high likelihood of finding it.
Okay. Okay. I
So
see.
it is very effective.
So, in other words, if I go see my doctor, right? You've convinced me now to go get screened. I go see my doctor.
Yeah, actually, tomorrow I'll call you back and check whether you got your PSA.
I will. I put myself on the spot, right?
Yeah.
I would. But so let's say I go see my doctor and he does the screening, gets me, the PSA test results, right? The PSA test results, I don't know how it's read, but assuming he tells me, hey, Mike, you're fine. There's nothing in there. Am I clear? Am I good to go? Is there anything to worry about?
For at least another year.
Okay,
So
for
what
another
I
year.
suggest is you add your PSA screening to your yearly checks.
Right.
So the PSA result comes out as a number. And in every blood test, there's a lower limit of normal and an upper limit of normal. And everything within those limits or reference range is normal. Anything higher than that is what we're concerned about.
Okay.
So the range is 0 to 4. So obviously you can't get more than 0. You can't get a negative PSA result.
Right.
Anything above 4 is what we're concerned about. But also, what's common in increased PSA levels is infections. You can have an infection, so a non-cancerous reason for a high PSA. And if for the first time you're noted to have a high PSA, you will most likely be treated with infections, or you can actually observe it, except it wouldn't be wise to wait a year to go back and check it. Your follow-up will be much, much sooner than a year, be a month or so. Have your PSA rechecked. And if it continues to increase, or if you've had antibiotics and it didn't come down,
Right.
or it even came down but didn't get back to 0, back to the reference range, back to less than 4, at that point you'd have to get to see a urologist
Okay.
for prostate gland biopsies, because at that time you need to know for a fact whether it's cancer or not.
Right. Right.
And
right.
that's done by getting a biopsy.
Okay. Dr. Osafo, one more question and then we'll go to John.
Okay.
Is there an age that you recommend getting screened? And I know you said it should be at least once a year, right?
Yes.
So say I'm 45. Do I have to get screened?
Right. There are different schools of thought based on different professional organizations.
Okay.
But I would say after the age of 40.
I see.
At least once a year when you do your labs, have a PSA in there.
Okay. Thank you so much, Dr. Osafo. I'm going to go to John. John, once again, you're welcome to Mustbe5 Radio.
Thanks, Michael.
And can you tell us, without prying too much into your personal life, can you tell us how your journey began and how you found out that something was not right?
Okay. Thanks again, Michael. Basically, I have family history. My dad passed at 62 years of prostate cancer.
Sorry to hear.
And he died in 94. And at the time, prostate cancer PSA test wasn't that known in Ghana. I'm from Ghana, so I quite remember it started with a urological problem. Having problem. They said it was a kidney. They went for tests for kidney. They couldn't find it. Later on, one experienced urologist said, "Look, let him go and test for prostate cancer." I think there was a test, not a PS, wasn't common at the time. And so, yes, we knew it was prostate. At the time, it got into his bone, so he passed. But then, as time went on, and then I read a lot on it. I realized that, look, if you have a family history, it's important that you start checking at a very early stage. So at age 37, I quite remember, that's when I started my annual medicals. And then keeping an eye on the PSA. However, whenever they went for the blood samples, I told them, look, you know what, just check everything. Check my liver, check my kidney, check everything. But my emphasis was on the PSA. PSA was good. It was I remember it was slightly under 1. But then as across the 40 line, I was still checking that. When I got to about 47,
I
was in London for a meeting, and then I told myself, look, let me just go walk into this clinic and run a test. Because I always had my test in Ghana. Let me just see whether, what another doctor would tell me outside the walls of Ghana. And then there was this doctor who said, look, at my age, the PSA was 3.25. He wasn't happy with the number. So I should go back to Ghana and then redo another test in 6 months to a year.
Okay.
So I repeated it. And then it had gone to 6. But my doctor in Ghana was saying, usually, like Dr. Osafo said, it's an infection, something. So they gave me antibiotics. Then it still, after a month, went down again. Then in another 6 months, then when I checked, then at 1050.
So after the antibiotics, it kind of went down.
After that antibiotics, really and truly, I can't remember whether I went for a test again or not.
Okay.
I can't remember because that's quite a lot. But I quite remember they said no possible infections could cause it. So they gave me a dose of antibiotics.
Okay.
I didn't go back to check. So I left it for another year for my annual checkup, sorry. Then when I checked again, it had gone to 78. Then I got scared. He got scared.
Right.
I says, no, you know what? Let me give you another bout. Go and do a urine test, sensitivity test for, I'm sure Dr. Osafo can explain better, just to check the urine. I went for a urine test.
Urinary tract infection, right?
Yes. Then he realized, he told me that, like he said, he says at the base of the bladder, so anything could go through. But then when I was in London, when I got to, in fact, from 6, let me backtrack a bit. From 6, I went to 10. And the 10, I went to London again.
Okay.
And then they ran me a test called cystoscopy, where they put a little tube through your penis to check whether there's any cancer in the urethra.
Right.
It is urethra, am I right?
Urethra, yeah.
Yeah, urethra. Then it went through to my kidney, because
No,
what
to
they
the
are saying is
bladder.
that
A cystoscopy
the bladder,
will
I'm sorry,
look up
the
into the
bladder.
bladder. Yeah.
The bladder, yes, sorry. The prostate area first, and then the bladder.
Yeah.
To
Okay.
check for bladder cancer, because that whole part of the body can let your PSA go up, I was told. Then they ran me X-rays in London. I couldn't find anything. Then they put he put his finger in my bum just to see whether he can feel a lump.
Okay.
He couldn't see anything. That was about PSA 10. So when I came back to Ghana, then my doctor says, well, if the UK guys say they don't see anything, let's repeat the test in a year's time. So now, when I repeated in a year's time, it went to 78. That's when they say I should go and do that sensitivity test for urine.
Right.
Give me a specific, a very old antibiotic to take. Apparently, that was a sensitivity. That was a drug that could deal with whatever they saw in my urine.
Okay.
After that, it says wait for another one month and check your PSA again. So I checked and went to 95. Then I got scared.
It just kept going up.
You know something? Just leave the country and get a doctor outside the walls of the country of Ghana to go further, because the biopsies are. He trained in Chicago. The doctor, he trained in Chicago, so he was like more of an American trained doctor.
Okay.
Who said, look, the best place to deal with this is in the States. So why don't you get a doctor and go to the States and get it fixed? And then, because what he was saying was that the biopsy in Ghana, should anything go wrong, there are very sensitive tissues around the prostate area.
Right.
Get it right, I may find myself in trouble. So he advised me to fly over to the States and get a doctor to help me fix the problem. So when I got to America,
right,
my PSA was 193 in January. And that was very scary. So they went through to biopsy. I did the biopsy, and then it came out that my Gleason scores were very high for all the tissues that they took out of the prostate. So then I started chemotherapy, and then for 3 years treatment, and then it vanished. I couldn't see. I had it all clear, and then put it out.
Okay.
And,
okay.
That's good. I'm currently going through reviews, because you don't have to keep your eye on the ball. Still keep your eye on the ball and let it go there. That's just like,
John, that's so great to hear.
To help me through the journey.
Right.
I went back and I called my classmates and I told them this was happening to me, so they should all go and check it out. And I shared my story. I think that was a big relief for me.
Right.
And people encouraged me as I went through my treatment. It's very depressing, and especially when you go through chemo, and I had to be home alone. So I tried to go to work, just to make sure that I talk to people and not be depressed, just sitting at home after a chemo treatment. So that's how I managed to go through my treatment.
Interesting. John, I'm going to come back to you. Thank you so much for sharing your story. And I believe that your story is going to make people get up and go see a doctor and get screened, right? Now, Dr. Osafo, I have a question. This is from a listener. So the listener is referring to kweku as a certain part of the male body, right? He says, with prostate cancer, will my kweku be affected?
Can it be affected?
Yes.
Yes, it can. And just a quick thing, listening to John's story,
right?
You see where he didn't have any symptoms at all. This was only because his PSA went up, and that's how it was found. And the PSA went up as high as 193. So just to illustrate the point where most of the time there are no symptoms associated with this, which is even more important, makes it even more important that screening PSA levels should be obtained. So coming back to the listener's question.
Right. I mean, he's asking about erectile dysfunction, but, you know.
Your kweku can be affected, especially depending on the kind of treatment you get.
Okay.
So just by having prostate cancer, it doesn't necessarily affect erection. It doesn't necessarily cause erectile dysfunction. Sometimes the treatment that's recommended, and if it's early stage, it will be between getting radiation or surgery. And the surgery that's done for prostate cancer requires taking the prostate gland out surgically and also lymph nodes in the pelvis. It's called a radical prostatectomy.
Okay.
Radiation is X-ray treatment aimed at the prostate gland to basically burn off the cancer cells. So those two treatment methods could cause erectile dysfunction, some of it reversible and others not so much. But if there's anything good about erectile dysfunction these days, there are medicines for it.
Right.
Viagra and Cialis can
Right.
be taken.
Right.
Yeah.
Okay. It's hot in the studio right now. Let's take a musical break and then we'll be back. I'll be back to you, Dr. Osafo, and then we'll take it from there.
Safari Blend Sunday, the best of curated high-life music on Mustbe5radio. Mustbe5radio.
Yes, and with AB Crystal in the background, we're back. We're talking about prostate cancer. Very, very interesting topic. And we're fortunate to have Dr. Osafo, Dr. David Osafo. He's a hematologist, oncologist, practicing out of Louisiana. And we also have with us John. For the purposes of the interview, we call him John. John is sharing his experience, his journey so far. We thank God so much for early screening. And we thank God also that he's just, monitoring right now because everything is clear. But we need to know more. Gentlemen, you're welcome back to the show.
Thank you.
All right. So I have a question, and I think my question, I'm not a scientist, but I think this will solve everybody's problems, I have a prostate above 50, right? I checked my last screening and everything is normal. There's no worries, there's no issue. And then I go back to my doctor and I say, you know what, this prostate, I don't even know what I use it for. Take it out. Let me prevent any future problems, any future prostate cancer issues, any future crazy numbers. Dr. Osafo, can I just do that, take the prostate out?
That would be quite a radical thing to do. If you don't have any problems with the organ, like you said, you're screening and your prostate gland is working normally, function is normal, PSA levels are within normal range, I wouldn't advise you to go and have a surgical procedure just for the sake of it to prevent future problems. There are other organs in the body too that you don't just go and remove. An example is your appendix.
Okay.
It really serves no meaningful purpose, but you wouldn't call up a surgeon and ask that they take your appendix out. Because although in the hands of an experienced surgeon, and if everything goes well, you recover from surgery fully, there could be surgical complications you put yourself at risk for. So I would not advise just going to have your prostate gland surgically removed to prevent future problems.
Interesting.
Treatment recommendation, yes. There's
it's better
when you have to have your prostate gland surgically removed. Okay,
so I noticed that recently I have problems urinating, right? Slow, weak urinary stream. I'm going to the bathroom more often. I have to get the job done at night, and Kweku is like, you know what, I'm not budging.
Right.
Does that mean I have prostate cancer?
No. What you have is a non-cancerous enlargement of the prostate gland. That medically is called benign prostatic hypertrophy. Benign being that meaning it's non-cancerous. And the prostate, of course, the prostatic refers to the prostate gland. And hypertrophy means an increase in size. So you have an enlarged prostate gland. That's non-cancerous.
Okay.
So the symptoms of BPH, or a non-cancerous enlarged prostate gland, are called prostatism. And there are one of many, or maybe you can have a number of these symptoms. One is hesitancy, meaning you feel like you want to pee, you get there, you get to the restroom, it takes a while before the stream starts.
Okay.
That's hesitancy. Another one is dribbling. You're done peeing. You know you're done. You're completely done. You put your penis back into your pants.
Right.
Later on, about a few minutes later, you feel that you're dribbling. You look at the front of your underwear. It's wet. You dribbled afterwards. Another one is frequency. You go so many times. You think you're done. You turn around an hour later. You feel like you want to pee. And you think to yourself, man, I just went.
Yeah.
But you got to go again. And sometimes you actually have to be proactive. If you're going to go on a long journey, you have a long drive ahead of you. you actually go and pee before you leave, because you don't want to get on the road and half an hour later or an hour and a half into your journey, you have to find a gas station to go and stop and go and pee. So all these symptoms are symptoms of an enlarged prostate gland, not necessarily prostate cancer.
So those are two different things.
Two totally different things. And that's why I was clear to say that it's a non-cancerous enlargement of the prostate gland.
Right.
And that's why the medical term actually starts with the word benign.
Right.
Benign meaning is non-cancerous.
But Doc, so do I need to get a separate screening for an enlarged prostate gland?
So when Sam was described, if you go to you have your normal physical exam.
Right.
At a certain age, especially starting at the age of 50.
Okay.
At 40, I would recommend that just check your PSA. And some physicians will do the prostate gland examination at 40, but definitely at 50, you have to have the prostate gland examined. And that's when you have a rectal exam, where the physician will insert his finger into your rectum. The prostate gland sits at the base of the bladder, but also it's right in front of the rectum. So inserting a finger into the rectum to feel the front of the rectum actually feels for the prostate gland. So that's how you do the physical exam for the gland.
I see.
And like I said, some physicians will start at 40, but at 50 you need to have a physical exam of the prostate gland. You can start your PSAs at 40.
All right. So we're going really deep, and you're sharing so much information right now. I have questions popping up. So
yeah,
with the rectal exam, right? You say 40, 45, right? Or 45 and up?
The actual physical for the prostate exam, the rectal exam, at 50.
Okay. Please describe.
For any reason.
I'm sorry?
For any reason.
Right.
Your doctor wants to do it early. It's fine. For instance, if your PSA goes up a little bit and he's not sure what's going on, he'll do it. So we're talking about screening exams when there's nothing wrong.
Right.
And that's what a screening exam is. When there's nothing wrong, but you're just checking.
Okay.
That's quite different from a diagnostic exam when the PSA has gone up.
Okay. So still prostate related, right? Can you briefly describe the process of the rectal exam? You said that the physician puts his finger in your rectum. Am I going to be awake when this is happening?
Oh, yes, you are awake. You are awake. He's going to be sterile, put gloves on, and put a lubricant on his finger, usually his index finger.
Right.
And he inserts that into your anal orifice through your anus into your rectum. And because the prostate gland is in front of the rectum, so with him you'll be lying on a bed or standing, bending over. He points his finger towards the front of your body.
Okay. So
if he inserts his finger into your rectum, he bends his index finger down, and that goes towards the front of your body. Okay. So the length of the index finger in a normal prostate gland, the length of the index finger should get to the top of the prostate gland. So then he feels the top on both sides. So from the middle down to the left side, and then back to the middle and down to the right side. Then he brings it down a little bit because he's examined the top of the gland. He brings it down a little bit to examine the middle of the gland. And he does the same thing with the bulb of the finger, examines the middle part of the prostate gland to the left side and to the right side, then down to the bottom, and same thing, both sides. So in that case, if there's a lump, a knot, or anything, it should be smooth.
Right.
There should be no bumps or anything.
Okay.
So if there's anything that he feels, then he'll document in his notes where he feels a knot or a bump, and then have you go and see a urologist.
Interesting. Now, this you recommend a doctor to do, right? You can ask your wife to do this test for you.
Because a layperson wouldn't know exactly what
they're looking for
or not.
I see. I have another question here. Thank you so much. I have another question. This says, an enlarged prostate, can that enlargement be reduced?
Can it be what? Reduced?
Reduced, yes.
Yes. Yes, there are medicines that will do that.
Okay.
And you will notice that if someone has an enlarged prostate gland and they take those medicines, they'll actually notice that the symptoms that we just talked about, the symptoms of prostatism, will improve. The hesitancy, dribbling, frequency will get better. And that's how you know that your prostate gland has begun to shrink back to the normal size.
I see. Thank you. We're talking prostate cancer today. We have Dr. David Osafo, and for the purposes of our interview, we have John, who is going through an experience with prostate cancer. Now, I have a question. My question says, are there additional tests that can be done besides the PSA?
No blood test. The PSA is one blood test that is done for prostate cancer.
Okay. So
now, if you're doing any other tests, then you're looking for more than just screening.
Right.
Then it means you suspect strongly that there's cancer, and then you're looking for spread.
Okay.
And those are X-ray tests, scans.
Oh, I see.
CT scans, bone scans, yeah.
Okay.
So there are other tests that are done, but in a different situation, not just for screening.
Then you're talking about imaging and all that.
Right.
Okay. All right. Now, is it good to, or will you recommend getting a second opinion?
Absolutely.
Okay.
Getting more opinions on a situation doesn't hurt at all.
Right. So, I'll come back to John in a second, but assuming my screen results came, all the numbers are elevated, right? And then you said the next step is to talk to a urologist to see if there's cancer and all that.
Right, about getting a biopsy.
Getting a biopsy, correct. What kind of treatment options are there for prostate cancer patients?
So for all cancers, and including prostate cancer, the treatment depends on the stage.
Okay.
So we had already briefly mentioned two kinds of treatment, surgery or radiation. And those are for early stage prostate cancer. So non-metastatic prostate cancer, that's what you do. Because that's specifically to that area of the body, the prostate gland and the pelvic area.
Interesting.
And there are other treatments which are you can also use those if it's a little bit of a higher stage, but still non-metastatic.
Right.
And there are injections. The scientific class of drugs or the pharmacological class of drugs that those injections belong to are called GnRH analogs. It stands for gonadotropin releasing hormone analogs.
Okay.
That's a fancy pharmacological term.
That's a big word.
You can use. There are tablets that you can take that are called androgen receptor inhibitors.
Okay.
So what these do is they treat the prostate cancer by inhibiting the gland's ability to produce testosterone, which feeds prostate cancer.
Right. Interesting.
The shot that I mentioned a little bit ago, those ones empty the body of the male sex hormone. And then the pills, whatever is left, they block the body's response to the testosterone.
Right.
So it inhibits the receptor. Yeah.
Interesting. So let's talk about side effects, and then we'll go to John. Dr. Osafo, what kind of side effects are we talking about for cancer treatment? And then also before that, what is the prognosis? So now I know that, okay, I have prostate cancer. What is the prognosis and what kind of side effects? do I get?
This depends on stage, and there are cure rates depending on what stage. So generally, the cure rates are higher with the earlier stages. So from stages 1 through 4, the cure rates decrease. And prostate cancer in particular is odd. In other solid tumors, which is breast cancer, lung cancer, ovarian cancer, all those things, stage 4 is an incurable cancer. For prostate cancer, there's actually stage 4A and stage 4B. So it's 4B and beyond that's not incurable. Now, when we say cancers are not curable, in oncology terms, what we mean is that cure in oncology is 5 years of remission. So if you go into remission, which means no evidence of cancer. If you start a treatment and after your treatment, there's no evidence of cancer, it means you went into remission.
Okay.
But if you stay in remission for 5 years, so every time you check, from the time remission was first documented up to year 5, and you're still in remission, then you're considered cured. If it came back 4 years, 11 months, and 29 days later, that means you did not get cured.
I see.
You had a long remission,
right,
and then had a recurrence. So remissions decrease, complete remissions decrease as you go from stages 1 through 4. In stage 4B is not curable, which means it doesn't mean that in 5 years you're not going to be here. It just means that you would have recurred. You recurred within 5 years.
Right.
So you didn't hit the benchmark, the measurement for cure. You recurred early. And it's still treatable. You can be treated with a recurrence and still go back into remission.
I see.
So regarding the side effects, your question about side effects.
Right.
Each treatment modality has side effects. So first, let's take surgery and radiation. Those side effects are similar, but carrying slightly different percentages. So that will be erectile dysfunction, which is very important, and is the most important side effect that the urologist or the radiation oncologist will discuss with you.
Okay.
Frankly, there's no man who wants to be impotent.
Right.
So that's a very important side effect to talk about. And then there will be incontinence. Usually after surgery, a urologist will tell you that your continence, which is your ability to control your urine, improves slowly over time. And in a number of weeks, about 3 weeks, sometimes even 6 weeks, what you achieve by that time is what you expect to be how continent you will for the rest of your life. And the same with radiation. With radiation in particular too, there might be a little bit of irritation to your rectum because of the radiation rays.
Right.
So each treatment has a slightly different side effect profile.
Okay.
And then when it comes to the shots that I talked about, so those ones, because the aim is to reduce the level of testosterone, you could begin to have certain symptoms like hot flashes, where you just break out in a sweat.
Okay.
Similar to a woman going through menopause.
Right, a hot flash, yeah.
And then it could also cause gynecomastia, which is a medical term for enlargement of your breast tissue. So a man would notice that his breast tissue is slightly bigger, or both are slightly bigger than they used to be. So those are also two common. There are other uncommon side effects that we look for with blood tests, like high cholesterol, when you're on the shots, those injections. The side effects of the pills, which block the body's response to testosterone, are similar to the side effects from the injections.
Thank you so much. Dr. Osafo. So I'm going to go back to John. John, once again, we really appreciate you coming on and discussing your experience. I want to find out, what was treatment like? What kind of treatment was it? I believe you said it was radiation?
In terms of treatments, I was given the shots, that Lupron shots that Dr. Saffold. But I did chemo too. I did chemo. I also had to go through those additional treatments that Dr. Saffold just listed. But then, like you rightly said, you would once you take those shots, you would go through some kind of menopausal, menopausal feel. So you can be. I mean, I could be driving and I feel cold all of a sudden, and I have to switch the air conditioning off.
Okay.
And I can feel hot and I have to switch the air conditioning on.
Right.
And then, that's the most. I would say the most prevalent side effects. And then what I did was I just bought a big bottle of flax from Walmart.
Okay.
Those big ones. I just fill it with ice. So when I feel hot inside,
right.
When I drink the water, ice and a lot of water. So when I just drink it, it kind of cools my inside.
Okay.
So that from within, and that's how I dealt with it. Yeah.
John, so how long was the treatment period? How long was it? Was it like a couple of months?
My fourth year.
Okay.
And my fourth year, yeah.
And when you were actively doing treatment, is this something you do daily? Do you go daily or weekly?
Michael, sorry, I missed that.
Oh, I'm saying that when you started treatment, right? Was it like a daily treatment or weekly treatment? How was it?
Oh, okay. So basically, I did. I ran chemo for 3 weeks. Every 3 weeks, I went for a cycle of chemo.
Okay.
And then I had to do my test before I go for the next cycle. I have to go for my PSA test to see whether the numbers are the numbers were reducing.
Right.
Which was the whole point. So maybe before I do the chemo 4, I just go and do my PSA test. The next day, I just go run the chemo. Chemo actually weakens you, so
it does. Yeah.
You pick it up again and go pick it up. But gradually, when I started from chemo 1 to chemo 6, my PSA dropped to was 1.3 from 193.
Oh wow!
By the time I was done with chemo.
Right. Interesting.
All the 6 cycles, I mean.
Right.
So I was lucky to have. I responded well to treatment in terms of numbers.
That's very good to hear, John. But John, once you started treatment, right? Was there anything that you had to avoid in terms of lifestyle?
Oh no, nothing, Michael. Back like that. Normally, I ate anything. I wasn't put up any kind of special diets. I ate anything I wanted to eat. The only thing I realized during that time was that I didn't crave for alcohol.
Okay.
For some reason, from time to time I take a bit of cognac or whiskey or beer, but during the whole period, I just went off alcohol. And then I know people think erectile dysfunction, but I was able to.
Kweku was fine.
Then out of the room, people shouldn't be scared that erectile dysfunction. No, I never went through that.
Right.
So the only thing that chemo, I lost my hair. The usual thing that you go through chemo, you lose your hair.
Okay.
And yes, and even my fingers, my nails became dark after chemo 4.
Right.
Chemo 1 to 3, my fingers my nails were clear. And what I did myself, like I remember when after chemo 2, I had a very itchy scalp. So as I tried to scratch it, then I saw my hair just falling off. I remember I was on my way home from work, and then what I did was I just went straight to when I got home, I took my shaving kits and then shaved everything off.
Right.
So it's a period that when you're going through, you need to be ahead. Don't let it, you shouldn't allow yourself to be depressed or discouraged or things that happen. I just shaved everything up before it starts falling off, and I feel very sad. And,
right. You're ahead of the game.
When you shave it off, to be ahead of the game, and then drink a lot of water. Still go to parties. I still attended my parties. There's that people will tell me, John, you're looking a bit, the hair comes, when the hair, during chemo, your hair becomes very thin. So those little ones that come, so every morning or every week, I got my wife to just take all that off. So I lived 6 months of a bald hair thing, which is more or less like fashion at home.
It's a style.
Yeah,
but
you don't need to tell people what's happening to you.
Right. But John, did you lose any weight?
Unfortunately for me, I was given a bit of steroids, so I put on a bit of weight.
Okay.
Yeah, so like I said, not too much of a weight per se, but I looked a bit round, which again, back at home, they'll say life is good, but I just kept quiet.
So interesting. John, what kind of support systems did you have? How did you go through all this?
Yes. Okay. So what I did was, at the time I was home with my first daughter had left for college. So I was home with my second daughter, who was writing her A levels, which is like the exam before you go to college. So I tried to hide myself from her. It's a big house, so she had a wing, and my wife was the main support, I must say. I'll say my wife and my employees at work, my PA, and then a few good friends, very good friends, knew what was happening. So that support was there. They came to visit me. But interestingly, Michael, I decided not to stay at home.
Okay.
Because once you stay at home, you think you are ill. I didn't want to accept the fact that I was ill and I was going. So I went to work. I'm a quant surveyor.
Okay.
So I went to site meetings. I went to my site meetings. I climbed the stairs. Days that I can't do the site and I go for the chemo, I just go home and rest. And at times I just go to the office and rather sleep in my office sofa rather than go home and rest, because it's so lonely at home. But if you're in the office, at least you get to talk to people and all of that. So that's what I did through and through. I never stayed at home.
I see.
Now the chemo days.
Right. Now, John, you don't have to answer this, but I'll ask you anyway. If you feel uncomfortable, just say you rather not say. At what stage were you told that you had prostate cancer?
At what stage?
Yes. Was it stage 1, stage 2, stage 3, stage 4?
Oh, stage 4A.
Stage 4A. Okay.
Yeah.
All right.
So I just got here right on. I just got to stage right on time.
Right.
I've moved to 4B, like David explained. I didn't know about B till he just said it.
He just mentioned it.
And God really loves me.
I'm telling you, it's
4A.
Yeah, it's really important for the screening to be done. I'm going to take it back to Dr. Osafo. I have a simple question here. The question says, what really causes prostate cancer?
So it really is a genetic mutation, because there are some people more susceptible to it than others, and that's why a family history is so important. Now, as far advanced, I'm sorry?
No, please go ahead.
Okay, as far advanced as we are in the diagnostics and treatment of prostate cancer, the exact genetic mutation has still not been identified. And we're hoping that it will be soon, because with that, the PSA will no longer be the screening test of choice.
Right.
The screening test of choice would rather be looking for that genetic mutation, so that if it's there, then you can then your question becomes important. Then you can decide to have your prostate gland removed, even if you don't have cancer.
Right.
If, for instance, that genetic mutation is found. There's a similar situation in breast and ovarian cancer. There's a gene called BRCA.
Okay.
If you have what's called the BRCA mutation, actually it's lack of a mutation. If you're BRCA positive, that's the situation where you find women having their ovaries removed or their breasts removed, even if they don't have ovarian or breast cancer. That's called a prophylactic oophorectomy or prophylactic bilateral mastectomies, or risk reduction mastectomies or oophorectomy. That's what that means. But that's only because with that, there's a known genetic mutation you can look for.
Okay.
So we know it's a genetic mutation. We don't know what it is yet. And that's the reason why it's prevalent in families. That's why family history is important.
So, Dr. Osafo, I'm 20 years old, right? And I'm currently listening to this interview. Is there something I can do apart from... Is there anything I can do to prevent prostate cancer?
No, actually, there's nothing,
There's nothing
for prevention.
Interesting. And then we're going to be rounding up shortly. I believe you touched on this briefly, but towards the end, I want to bring it up again. Can prostate be cured totally or managed? But that depends on the stage, right?
Yes, that depends on the stage. So the cure rates are higher with the earlier stages.
Right. Interesting. Thank you so much. I want to say a big thank you for both of you coming on the show and bringing us so much light about prostate cancer. I'm going to give the opportunity to John to just say something, a recommendation to the listeners. Tell them what your advice is with, getting screened, and if you get screened, what next to do. John, please, this is for you.
Right. Oh, thanks, Michael. So tell listeners, what I would advise strongly is that for those who have either an uncle or a father who has died of prostate cancer,
Or a brother.
Thank you, doctor. You shouldn't joke with it. Just do your annual screening. I mean, when I turned 50, my doctor told me to do half-yearly checks. I know, but then when I got treated, I was doing every quarter, just because I had been diagnosed with it. But for the time before I was diagnosed, I was doing half year, every 6 months. I was checking, and like the Dr. said, I diagnosed my own illness, more for want of a better word.
Right.
I went to doctors with my labs for 10 years. I quite remember the doctor in London said, "What work do I do as a mechanic surveyor?" I says, "No wonder, because I even drew my graphs to see where I was 10 years ago, 9 years, 8 years, and everything was there clearly that my PSA was just rising."
Okay.
And I found myself. I would plead with listeners to not to joke with it, especially if you have that family history. And even if you don't have a family history, it's still important that you do the annual medicals, because it's only through that any doctor can save your life.
John,
even if you are diagnosed with it too, it's not scary. I was stage 4A. I'm still here.
Right.
So whatever stage you find yourself, just go and see the right doctors, urologists, and they will help you through it. Don't be scared or don't be worried. Back at home, there's a little myth about the fact that I can't see myself, me a whole man, having another man's finger in my anus.
Your back,
yeah. I'm sorry. That's the only way they can check it for you.
But John, are there any support groups out there that you can join and be part of?
Yes, we've actually formed a support group back with the breast cancer, and they always go hand in hand.
Right.
For the women, it's always breast cancer. For the men, so we formed a group back at home where we do give lectures to students and year groups, and even to Rotary. I'm a member of the Rotary Club, where if it's September, which is breast cancer month, and October being prostate cancer month, we make sure we have speakers and people like myself who've actually been survivors to give talks to people.
Right.
People get scared when they hear the word cancer, but
I know.
Similarly, I had the same feeling, but now I've realized it's curable. It's just a name. You shouldn't get scared because it's cancer. It's cured. You can be cured. So even if you can't get cured, I think I'm sure Dr. Osafo will say it can be managed. Yes. So it's anything that should be.
Thank you so much. Right. Thank you so much, John. Final question goes to Dr. David Osafo. So what do you have? So all the listeners are sitting in front of you in your consulting room. Talk to us. Tell us something that will make us go get screened, go get checked up.
It is easily available. It's a blood test that's quite cheap. There is nothing stopping you from denying yourself a chance to look for prostate cancer and possibly catch. You see, here's the thing: we don't wish this on anyone. True. But the thing is, because we can't control who gets it and doesn't, If you're going to get it, then let's catch it early so we can cure it. And that's my advice to everyone.
A quick one. Where do I get screened? Do I have to go through my doctor, or I can go to Rite Aid or Walgreens? What is that process?
No, you would have to go through a doctor for him to order it. It has to be a doctor's order to the lab.
Okay.
For the lab to run that test for you.
I see.
And the results will go back to the doctor,
right.
And he interprets it and tells you the significance of what your number is.
Okay. Final question just came in. I believe this is a myth somebody wants to debunk. Is it true that having more sex prevents prostate issues? Is that correct? Is there a thing like that?
It's been talked about a lot. There is no scientific research to support that.
Okay. All right.
But I'm not going to say stop it.
Right.
Because the reverse is also true. There's no evidence that lack of sex prevents prostate cancer or causes prostate cancer.
Causes, right.
So to each his own. Do what you want to do, what you have available.
Just keep doing. Thank you so much, Dr. David Osafo and John, for your time. We've just gone over the hour. I promised I was going to keep it within 1 hour, but I want to say a big thank you. If we need you again, we might call on you, but you've touched on almost all the questions, all the myths, and all the issues that were hanging out there, the myths and everything. And I just want to say a big thank you so much for coming, John and Dr. Osafo.
Well, thank you so much for having us, Mike. It's been good.
Thank you. Bye for now.
Thanks, Mike.
Bye.
Mustbe5 Radio, where good music lives.
This is Mustbe5 Radio.